Hi, my name is Marjorie Erdmann, and I work at Oklahoma State University Center for Health Systems Innovation, along with Ipe, Carrie, and William. I'm presenting Innovation of Rurally Sustainable Integrated Care Management Model, an innovation process, and a model. There are increasing calls for integration of mental health and physical health care in the marketplace, where the two primarily remain siloed. Across the US, payers like Medicaid have attempted to bridge this gap through care management with a focus on improving patient outcomes. In this process, there's been little attention paid to the workflow, the processes, and the models that efficiently address this gap. This is especially important in rural areas that suffer from workforce and healthcare shortages. Many of the integrated care models that we see are really conceptual models. They don't tell us how would knowledge flow, how would information flow, how would care flow. It's really a conceptual idea that everybody would be coordinated around a patient. We think that this is a gap, and addressing this gap will create better models. So our methods were to really partner in the field with 7 integrated care sites, 4 rural, 3 urban. We did 3 assessment stages. We looked at, we did attended meetings, attended care, direct observation. We transformed that into a formal assessment that you'll see over here. It's a 30-page or 30-item formal assessment. And in a later slide, I'll show you visualization of barriers. Then we went through an innovation stage to try to resolve the issues that we identified. The first thing that we noticed is in the formal statistical assessment, really the critical nature of the involvement of the medical consultant team. It was predictive of the quality of care management that was provided and the overall efficiency of the program. It really was an upstream issue that many efficiencies came from. In the visualization of opportunities, the assessment that we had identified 6 core program components, and we communicated these components to the agencies in different ways. The first one was a radar graph where we showed the 6 components, lack of efficiencies on the outside and high efficiencies on the inside. We wanted to communicate something that we called workforce stretch, which is basically the effort, the manpower a workforce has to do when the system or the product or the tool that they need is inefficient, what they have to do to close that gap. So you can see here on the left, Agency A had a lot of efficiency gaps and was creating a lot of extra workforce effort versus Agency B where it was tighter. Most of the agencies sort of had a mix, like Agency F and E here. We also communicated to them, we didn't want to compare agencies against each other because they vary so different in their resources. So what we did was we measured where their current efficiency was, what we really thought their optimum, if everything was perfect, given some of the constraints that they face in their location, for example, or their financial resources, what was really the optimum that they could reach, and then what we thought was reasonable for them to reach. So we gave them this reasonable goal. We showed them what their current efficiency was and gave them information like these targets on how to close that gap. What we found in addition to these was that the patient journey was very complex and protracted, and diversity in care models was really much greater than what we expected. So this is talking a little bit about that. And these were really some aha moments. When you looked at the process for admission into the program, and each time a color changes, it's a different person that's the patient's getting handed off to. They started to realize why from enthusiasm of a patient from initiation to when they finally finish the whole process may have waned, because this may take hours. In some cases, it was protracted. And so really simplifying this patient journey was one of our key ahas to creating efficiency for not only the patient, but also for all these people and workers and processes involved. The other thing was there really was a great diversity in care models. And this is the crux of a conceptual model doesn't tell you how to go about implementing your resources. So while the resources you can tell are relatively the same in each one of these models, they were deployed very differently. And the further away that the expertise was to the care management itself, the more difficult and the more inefficient that the care was given. We looked at rural comparables to urban, and really we found a couple of things. If you notice here, like while there's a gap, 5 to 10% current rural to urban, the gap's very small, really. And so they have the ability to put together most of the core components right over here. A lot of their inefficiency that they would be unable to resolve are driven by their population, how high the chronicity level of population. And that was measured by county. So we use the county health statistics for that. So you can see that all things being equal, the rural clinics were able and would be able to address most of the efficiencies and utilize their resources. Innovating the care model, we really wanted to solve a lot of the disconnects and the duplications. And so we used just the existing program components. These were the program components. This was kind of how the model started off. Most people had the client go to the therapist, and then I had case managers assisting the therapist, and then this care manager, nurse care manager, was more of a supervisor role. What we did is we wanted to transfer and elevate the nurse to be sort of the center of care, to be what we call the patient owner. And also this creates clinical competence to be a proper conduit for clinical excellence into the care. So this, as it turns out, ended up really simplifying the patient journey. The client received the help that they were seeking upon presentation. They quickly got associated with a nurse care manager who could manage a lot of the planning for them, for their care, for their integrated care. So the conclusion was really that the innovation provides promising solutions for rural health, and rural health just needed help putting together their current resources in a more efficient way. It was something that we took away was workforces attempting to integrate healthcare face many barriers, and really the inclination is to resolve these by just increasing the care manager workload and having them stretch and stretch more, or push responsibilities to patients like that long patient journey. Really creating a medically tight model, while that might take some extra effort, is well worth the effort. It pays off in a lot of downstream innovations, and it helps control workload inflation and patient burden. Through model innovation and standardization, helping everybody have the same target, clear organization and operational targets were created to improve quality of care, reduce workforce burden, and simplify the patient experience, all without increasing cost. So understanding this workflow, these processes, and these models of integrated care is important. In this model here, there is a flow of care to the patient, and it's clear. And it's a clear target. You know how to organize your workforce and your resources. So with that, that's how we innovated integrated care to be viable and sustainable in rural markets as well. If you're interested in rural health innovation, I'm Marjorie Erdmann. This is my email address. Paramel, Carrie Marshall, and William Paiva are partners on this project, and a special acknowledgement to Dr. Sarah Coffey for her confidence and her partnership and guidance in integrated care management and this innovation in Denver. We are all inspired by her tireless passion and high quality compassionate care that encompasses really the whole person. Thank you.